I'm going to go ahead and start recording. So welcome everyone. Glad to have you here today for our monthly Brownbag webinar. For those of you that are new to the GSU Prevention Research Center webinars, I'd like to give just a brief introduction. So the Prevention Research Centers are a network of CDC-funded academic research facilities in the United States that study how people and their communities can avoid or counter the risks of chronic illnesses. Our PRC at Georgia State University is headquartered on the Clarkston campus at Perimeter College. And we work with community organizations, state and local governments, residents, and other partners in Clarkston, Georgia, to develop, implement, and evaluate culturally and linguistically appropriate interventions to address disparities and determinants of health for migrants and refugees, and then to disseminate that work at the community, state, and national level. I'm really thrilled today to have not just Dr. Yun with us, but her whole team of colleagues to share some of their really important work regarding culturally and I'm assuming linguistically responsive information about childhood vaccination safety. And just want to very briefly tell you a bit about Dr. Yun, and then her colleagues will also introduce themselves as well. Katherine Yun received her medical degree from Harvard and completed her residency in pediatrics at Yale. She was a Robert Wood Johnson Foundation clinical scholar and earned her master's in health sciences research from Yale. And while at Yale, she was the supervising physician in the Yale New Haven Hospital Pediatric Refugee Clinic. And she's currently an assistant professor of pediatrics at the University of Pennsylvania School of Medicine, and attending physician in the Division of General Pediatrics and the Refugee Health Program at Children's Hospital of Philadelphia. So we are really pleased to welcome her and her entire team of colleagues who are going to talk to us today. And then we will have some time for discussion. So let me stop sharing at that point. Dr. Yun, please feel free to go ahead and share your screen.
Great. Thank you so much. It is just such a pleasure to be here with this group. GSU PRC has such an incredible reputation for the work that you do in engagement with communities. And so I think being able to talk about community and culturally specific childhood vaccine safety education materials for our Afghan, Congolese, and Ukrainian communities with this group is just going to be such an interesting and enlightening experience for us as well. And thank you for that very kind introduction. We want to acknowledge that I think many of you and us also work with communities who are directly affected by armed conflict. And so it's also very meaningful for us today when we think about our colleagues around the world to know that there is this group who are working in support of community. So thank you. And I will hand things over to my colleague Nadej to introduce herself.
Hello, everyone. My name is Nadej Mutoni Mudengi. I am a bilingual clinical research coordinator at the Children's Hospital of Philadelphia, and I have worked as a professional medical interpreter for the last 10 years. I am currently a student at Drexel University. It's such an honor to be here today. Thank you.
Beth.
Good morning. My name is Beth Lawson-Hahn. I'm a general pediatrician at the University of Washington and an assistant professor, and I serve as a medical advisor to the International Organization for Migration. As my colleagues mentioned, really honored to be here with you in conversation this morning.
Hi, everyone. My name is Amina Ibrahim, and I'm Program Operations Specialist, University of Washington, working in the Pediatrics Department. And I'm so grateful to be here. Thank you for having us.
So we have no conflicts of interest to disclose, but we do want to acknowledge that we are part of an even larger group called the Multilingual Health Education Alliance, comprised of colleagues from NRC RIM, University of Washington, MEDS in Erie, Pennsylvania, Denver Health, and Children's Hospital of Philadelphia. And if everyone could be here, I think they would be, but schedules are a little tight. And I think most important, we want to acknowledge that the community experts who have helped to shape this project are the members of our working groups, the Afghan working group, the Congolese DRC working group, and the Ukrainian working group. And so we thank them for their insight and their expertise. Our learning objectives, this is an advanced audience, but in reflection with you today, we hope to share some about the complexities of vaccine safety communication with diverse newcomer communities, thinking about these three groups specifically. We'd like to describe different strategies for successfully recruiting, retaining, and recognizing community expertise. Not all of the strategies, but one that we've used for this project. And we hope to share a description of our project around childhood vaccine safety communication, essentially as a case study that I hope will allow you to visualize one process we've used for developing community-informed, multilingual health and public health education materials. And why vaccination and why focus on these three newcomer communities? So like many of you, and we know about the incredible work you've been doing over the past 3 years, we were deeply immersed in the COVID pandemic response, really from the very beginning. We, I think, saw collectively across our organizations that communities who we had worked with, specifically newcomer communities who spoke languages other than English and Spanish, were by and large not receiving health and public health information that they needed to protect their families at the start of the pandemic. And then as the pandemic evolved towards vaccination as a protection strategy, we also saw that information about the vaccines, and the safety of the vaccines was not available in those languages or through the communication channels that would make the most sense. And I think, like many of you, we tried to find the lotus flower blooming from the mud in all of this. And one of the things that we want to come away from the pandemic with is a sense that we can do better moving into the future. And so we had the opportunity, with a little bit of funding support from CDC, to convene a working group comprised predominantly of African and Asian immigrant parents, community leaders, and youth in 2022. And we asked them to reflect with us on what had gone well in the vaccine response for children during the pandemic and what perhaps we could do better. And when we think about the guidance they shared with us about what we could do better, it really is summarized by our colleague, Adrian Matadi, who is part of that working group and is part of our MHEAL collaborative as well. And he said that when you don't offer timely and trustworthy information, misinformation will fill the gap. And to put this in even more stark terms, one of our working group members shared that the damage that misinformation and disinformation caused had already been done. And so up to now, we're paying a huge price of spending too much time to educate after the damage, basically repairing the wound. And so, we think about tertiary, secondary, and primary prevention. To me, this is a story of tertiary prevention. You're trying to undo damage that's been done. But how can we, again, moving forward, think about primary prevention? How can we get out ahead of misinformation about vaccines and instead help communities receive the information they want to receive so that they will have reliable information from the beginning? And I know this is an incredibly busy slide, but I have given you the reference because it is open source, and so you'll be able to see it in better detail on your own. But this is a theory of change that was created by a group of academic and community and health systems stakeholders together from underserved communities, including newcomer communities in California, regarding the pandemic. And I just want to highlight that in this theory of change for outcomes, decrease barriers to vaccination, increase knowledge of vaccines and vaccine uptake, one of the key elements that was highlighted was, again, these information barriers and mistrust. And so this is a theory of change that I think resonates with everybody in this group today, but it talks about making sure that communities have access to trusted, truthful information from government sources, that information is reliable and in multiple language to offer consistent messages addressing people's fears and questions, and that there is investment in trusted, diverse leaders who know about formal and informal networks to reach out and share information for communities. And I think that really encapsulates the approach that we have tried to take now in this childhood vaccine safety communication work. And, I think we all want to acknowledge that there is an incredible wealth of technical expertise of health and public health stakeholders who have truthful information they would like to share. But we face pretty common barriers, and these come up over and over. People will say, well, we don't know which message is going to resonate with a specific newcomer community. They might not know how to ensure that message is being conveyed accurately in the languages spoken by that community. Or they might not know where or how to share those messages to ensure visibility and trustworthiness. And so really concretely, when we were thinking about our childhood vaccine safety work, questions that came up about messages were things like, well, what do we do if families are tired of hearing only about COVID-19 vaccines? What do we do if a language is spoken across a large geographic expanse and there might be multiple regional variations in language use? And again, how do you get credible information into the hands of people through a channel they like? Lots of questions about WhatsApp always come up. And so the framework that or the case study we're going to share with you is really rooted in a community-informed health education approach. And I want to emphasize, and we'll talk a little bit more about this, that a community-informed approach is not the only approach. We could envision a future in which all public health messaging is really community-based and community-driven. But until we get there, we think about a community-informed approach as an approach in which individuals with technical expertise, such as public health experts or pediatricians, are able to partner with individuals who have community expertise, listen to what they tell us, be accountable for creating materials that align with what a community shares they need, and then providing those materials in turn. And so it starts with listening. And listening is really important because the process we're going to describe in this case study involves 5 distinct steps: convening a working group, developing messages, designing materials, translation with community consultation, and then dissemination via preferred channels. But if you're going to go through a planning and budgeting process, if you're going to think about your human resources, the listening phase where you're just present in communities, talking to colleagues from communities is really important because it's going to tell you which of these steps is going to require the biggest lift, which of these steps is going to be more straightforward, and it's going to allow you to plan appropriately. In our case, when we did our listening, that is what led us to decide that we wanted to convene working groups as our first step. And there were there were many reasons for this, but 3 of them were, we knew we were going to be engaging with communities, especially the Afghan and Congolese communities, where there's a lot of regional differences in language use. So we wanted to have multiple stakeholders with multiple perspectives on language use. We also knew that these were communities where there was a lot of internal diversity. And so a working group with many people allows you to tap into some of that diversity and have it represented. And then we also knew that because we were focusing on newcomer communities, newcomer Afghan, newcomer Ukrainian, newcomer Congolese from DRC, these were groups that had been somewhat excluded from prior health and public health communication. And so having a working group also meant expanding our reach. These are individuals who would also be able to play a role in partnership with us in dissemination. And so what did that mean in terms of convening a working group? You all have done this before, I know. But it means having leadership from within the community, whether you're hiring someone into your team or partnering with an established community organization. We think about the number of people we want to have involved, and in our prior work, between 5 and 10 has seemed to be about the right number. And we budget to value people's time. This is time, it's expertise they're spending, and we budget accordingly. And again, going back to that idea of internal diversity within communities, we're thinking about individuals with broad experience with the community, who have different characteristics in common with the subgroups we are hoping to reach, like parents of minor children, for example, and parents in different age ranges, both mothers and fathers. We wanted to make sure that everybody would have respect for diverse perspectives and experiences so people could really share with one another using active listening, a good interest in the topic in hand, and then going back to that question about the diversity of language use, that folks would have the language skills that would help ensure that any translation work that was done met their standards and had their approval. We want to acknowledge there are many alternatives to convening a working group. As mentioned, you could have a very wonderful community-driven process in which really the community is doing the project, it's driven by them, started by them, and really public health or healthcare is playing only a technical role, if any. And then, of course, on the far end of the spectrum, there are projects that are only done by public health or healthcare stakeholders with no community engagement. But there is this middle ground where whether you're working with a community-based consultant with a lot of experience working across a community and have sort of grass tops expertise they're bringing to bear, or a working group, you're able to bring in that community voice and hold yourself accountable to individuals from the communities themselves. And so with that description of our process for creating a working group, I would like to hand things over to my colleague Nadej, who will talk about our process for developing messages.
Thank you, Dr. Kate. I will continue from where Dr. Kate has started, how to develop messages in plain language. Thank you. First step will be the content of the message. While creating content, it is important to keep in mind if the message resonates with the community. There are vaccine messages that are unique for newcomers' families, for example, including something like, your child may need additional vaccines after arriving in the United States, to help parents understand why the child may need additional vaccine, even if they had prior vaccination before moving to the United States. From the conversations we had with the working groups in the beginning of this project, they also recommended us to talk about all the childhood vaccinations and include the COVID-19 vaccine as one of the many. They told us that people were just tired of hearing only about COVID vaccine all the time, but they hope that by normalizing COVID vaccine as part of the routine schedule, this will bring interest to their communities. They saw this as a good opportunity to highlight all the vaccines, including but not only COVID-19 vaccines, strengthen the body's natural immune systems. Next, please. The next step is to understand what messages the community need, because you don't know until you know. Until we started having conversations with our working groups members, we didn't know that people in this community wanted to know how many vaccines their children are supposed to get and when they are supposed to get them. For instance, the idea of providing them the vaccine schedule in their own language where they can keep updated with their children's vaccination, especially when the doctor talked about the catch-up dose at different ages. And people also needed to know that there are organizations like CDC and FDA that monitor vaccine carefully for quality and safety purposes. Next, please. So after understanding what the messages the community needed, we wanted to know how to develop a format that will be engaging and informative for each specific community. We understood that each community has a preferred format on how they receive messages. For example, the Afghan community members recommended creating brochures for their community because they have many community health workers with a public health background, but they didn't know which vaccines are recommended for the children in the United States when they are recommended, or how the US ensures vaccines are safe. For the Congolese community members, they recommended to create a short video that can be easily shared on social media platforms to increase awareness within this community. And for the Ukrainian community members, they recommended us to create a poster that can be shared on both social media and community organizations and clinics, like other educational materials. And then we ended up creating the website where people can have an easy access to look things up and read more in their own languages. Next slide, please. So how do you design materials? So now we have the content and the format that the community recommended. The next step, which is very important, was to design material. So then how do you design the messaging material that everyone can comprehend? It is very important to use a plain language when developing materials. So plain language, by definition, is writing designed to ensure the reader understands as quickly, easily, and completely as possible. As a recommendation, pretty much keep your material at a 6th grade comprehension level. Use the everyday language. So we ended up developing a glossary using plain language to be able to understand what words will be well understood by the community once they are translated. Next slide, please. So one example from the Kinyarwanda glossary, as you can see here, allergy is translated as ifuruta. The word ifuruta, in English, it means skin rash. As you know, a skin rash can be caused by an allergy, but not all allergies cause skin rashes, and not all skin rashes are caused by allergies. Instead, our group opted for a short phrase that did not rely on a high level of medical literacy and offer a description. Impinduka z'umubiri zatewe n'ikintu ubusanzwe kiba atari ikibazo kuri benshi, which means the change in the body caused by something or a substance that usually doesn't cause trouble to most people. Additionally, we note that some people will understand the borrowed word allergy. However, many people in the Congolese community are not aware that allergies are a biological reaction rather than being picky. Next slide, please. Another example from the Kiswahili material, so when we created the video script, we started by developing a script in English because the Congolese community recommended us to create a short video. So as you can see here, when we started creating the script in English, we started by saying vaccines are safe and important to protect our children against illness. And then we quickly noticed that this sentence is not easy to be accurately translated in Kiswahili. So our team decided about another way that we can say what we needed to be communicated with that, and then we ended up concluding on choosing the phrase, we can choose vaccine, we can trust vaccines. So vaccine can be trusted is easily translated in Kiswahili, and it keeps the context of the original text and its meaning. So this to show you that even phrases that seems very straightforward in English may not be easily to translate. So the video script we created by carefully choosing familiar words and concepts versus words that may be very difficult to translate. So thank you. I will pass this to Dr. Beth to continue.
Thank you, Nadej. So I'm going to build from where Nadej left off, starting with step number 3, which is to design the materials. Next slide. So now that you've developed your message, you're going to start thinking about how you want the materials to look as they go out into the world. Our team found it really helpful to show examples of specific material types to inform the conversation with our working group members. And then once we showed that the material, like for example, the picture in the far right corner of what I imagine to be a mother and daughter, we asked team members to explain the things that they liked. And so one group shared with us that they liked that this image was multi-generational, and they liked that it emphasized protection as one of the primary motivators for vaccination. But what they didn't like about it was that it felt like a postcard, and they wanted the materials that we were sharing to have more information on it. Another example of this was when we were working on developing a video. We showed pictures with a voiceover. We showed an example of a person just speaking on their own, and we showed an animated clip so that people could choose between the things that they felt most resonant to them. We also asked for descriptions of colors and what they meant to the working group members. Many of the groups shared that they liked colors that were representative of flags of places that they'd previously called home. And one group specifically identified that red brought up the idea of blood to them, and they didn't want that to be a part of the imaging or a big part of the imagery. And finally, we talked about highlighting lessons that are passed down in the community, recognizing that these types of lessons are often resonant across community members and across generations. And one of the things that came up often was putting family and community first. Next slide. Once you've decided and have examples in mind of how you're going to design the materials, you can start to think about writing or the copy of what the message is going to be. Really, this is guided by the type of material. Are you writing a script for a video? Are you writing text for display? And this will help you draw on the talents of your team to figure out who is best positioned to write something like this. Of course, thinking about community-specific framing is important, and that is really based on the conversation that Nadej highlighted around community-specific framing of the messages. We recommend ensuring alignment with authoritative and trusted sources. Many of our working group members highlighted existing sources or the absence of existing sources. And so we saw this as an opportunity to draw people back, for example, to resources from CDC or from FDA about how messaging, how vaccine messaging moves forward and how safety messaging can be in alignment with these sources. So they don't look different. We don't want to draw up more questions. We want to reassure people that we're all on the same page. And finally, the importance, as Nadej mentioned, of utilizing plain language. Next slide. You can see from this figure on the right that we were utilizing a human-centered design approach. So we worked on designing the material, and then we sought to get group leader input, and then we iterated or revised the design, and then we got working group member input, and then we redesigned the materials. So how did we do this? We tried to keep it simple. We did this within Canva, so an existing platform. We didn't try to all of a sudden become graphic designers, and that made a lot of difference as we tried to iterate on things. If you have a graphic designer on your team, kudos to you, but we wanted to keep it simple. One of the things that was important to consider is the size and the shape of the materials you're developing. Are you developing something that's going to go on Facebook? Therefore, should it be rectangular? Are you designing something to go on Instagram? In which case it should be a square. And then also thinking about things like test printing. You don't want to get to the end of your design process and realize you've been designing something that's 3 by 5, as in 3 feet by 5 feet versus 3 inches by 5 inches. So thinking through what that will look like. We also found it really helpful to think through layout and thinking about where blank space is located, recognizing that different characters in different languages around the world take up different amounts of space. And if you really need to be mindful about the space as you lay things out. Similarly, since some languages are written left to right and others right to left, we wanted to make sure that anything we designed could work for either, since we were designing in English due to the language capabilities of our team, but some of the languages we were partnering with, like Dari, for example, is written right to left. We also thought a lot about visuals and ensuring they felt representative to the communities we were partnering with. And so we chose to pay to license images from iStock Getty Images, which has tens of thousands of images that may be in alignment with the community that you're partnering with. But we also chose to budget for illustrations, and we'll show you an example of why that was, because you sometimes can't even find representative images even when there are tens of thousands. And I'm sure we've all experienced that in projects that we've worked on. We also tried to ensure we had enough time, about 2 to 3 meetings for that iteration step or that revision of the design to make sure we were getting it just right. And then we chose to track the iterations of design in a PowerPoint. I thought about this as a lab notebook, this idea that you would want to remember how things looked, provide feedback in the notes section of your PowerPoint slide, and then update the image and have a record of the next iteration you had. And I'll show you an example of that here on the next slide. So on the left slide, this is the first example we made of the Afghan vaccine brochure. So we heard what the working group members said and what our working group leader said, and chose to incorporate diamond imagery that was common in textiles from Afghanistan. We selected images from ISAC Getty Images that members of our team thought might be representative of Afghan families. And what we learned from our working group members and working group leader was that the image didn't feel representative of Afghan families, and that the way that the women's hijab was tied was too tight and not representative of most women, and that the clothing wasn't colorful and celebratory in the way that much Afghan clothing is. And so our team reconvened and iterated and talked about hiring Dr. Lily Tang, who's a pediatrician and an illustrator, to develop a representative image based on the guidance of our Afghan working group leader. And so you can see in this image on the right, we kept some of the diamonds motif of the textile, we added an Afghan flag, and in particular, the real highlight is the illustration that Dr. Lily Tang made, which is representative of Afghan families, including really specific embroidery details of flowers and ensuring that all the family members are wearing culturally celebrated clothing. Next slide. For the Ukrainian poster, you can see we also went through an iterative process. There was a lot of celebration on the team about thinking about multi-generational families, but they wanted the family to look like they were interacting with one another. So you can see that we shifted the images, and then we also chose an image that included a heart that is the colors of the Ukrainian flag. And so that was the way we were able to weave the Ukrainian flag into this image. Additionally, the group wanted there to be more specific details about protection as well as safety and why we felt that vaccines were safe. And so we actually added more text to this poster based on the feedback of the working group. Next slide. And finally, one other example of iterative design, as Nadej had mentioned, we learned from the working groups that they really wanted to have their own linguistically tailored vaccine schedule that was built from the CDC's recommended guidance. And so what you can see on the left is a schedule that's available through the AAP and CDC. And on the right, it's what we developed based on the recommendations from CDC. And we elected to actually add check boxes to represent the number of vaccines you would have, because the concept that you would understand that you would receive Hep B one time between 6 months and 18 months is not necessarily intuitive unless you're familiar with this vaccine schedule structure. Next slide. So now we'll go on to step 4, which is translation with community consultation. This is likely something you've thought about as you've laid out this process, but now we're actually at the step where we're doing that. Next slide. So thinking about that, ideally you've selected a translation vendor earlier on in order to ensure that you're going to have quality assurance of your materials. Recognizing, for example, that there are regional variations in language use. If you remember back to the slide that Dr. Kate showed, we talked about the DRC Kiswahili might be different from Tanzanian Kiswahili as we look at the region of East Africa where people might have fled from DRC. Ideally, you'd want to have someone or a translation vendor who has experience with different file formats. So if you've been developing your materials in Canva and that vendor doesn't have experience in Canva, then you're going to be doing a lot of flipping back and forth, and it really invites a lot of room for error. So it might be worthwhile to search around with translation vendors to ensure they can work in your preferred modality. As I'd mentioned earlier, experience formatting right to left is critical for ensuring that the materials are accurate. And then we recommend selecting a community consultant, someone who's knowledgeable about language use in the community of interest, and that they can have attention to accuracy and cultural appropriateness. And then, of course, the working group should approve the final version. And I'll pass things over to Amina from here.
Thank you, Beth. Now that we've created the material, the 5th step is dissemination via preferred channels. Something that we really listened to the working group leaders, how they wanted that to happen. Next slide. So the first step of dissemination is like identifying the who. So listening to community groups on how to disseminate. We found that not one way or one form of dissemination works for all groups. So really taking into account what community members feel like is the best way to disseminate. Also thinking about dissemination geographical priority. So one thing I did early on was identifying the top 5 cities and states that each group resettled in originally to see where the biggest communities huddle were. Something that was really important that came up a lot in our working groups was that not every community leader wants to be a public disseminator. And that's something to really take note of and honor. We found that one of the working groups that we worked with was very eager to reach out to people to disseminate the information. They wanted to do it within their private, friend groups on WhatsApp and on Facebook. And another working group community did not want to publicly disseminate. They kind of wanted us to take the lead, and they didn't necessarily want to share on their personal platforms. And I think that's an important boundary to respect as you work with them. And then finding different modalities. So thinking of all the ways you can disseminate social media, mosques, cultural orientation classes. We had every working group identify what they felt like was, and then we also built on it on our own and did our own research as well. Connecting with both national and local organizations. So thinking of these organizations that have maybe offices and communities all throughout the state, and then also thinking of really specific, geographical places. So thinking specific mosques, thinking of specific resettlement agencies in certain cities that primarily work with the communities that we were working with. And then I think when it comes to disseminating, having really specific asks for organizations. So kind of identifying what you want each organization to do, whether it's posting on a newsletter or posting on social media, disseminating the flyers to their community leaders that they serve every day. Just really specific, being specific about what you want the organization to do when you give them the material that you've worked on. Next slide. The next step of dissemination, again, it's kind of also a how. I think it's really important to allocate at least a third of your resources, so time, effort, and budget to the dissemination process to make sure that all the work that you've created is getting properly disseminated and out there in the world to benefit the most amount of people. Prepare to be surprised. We found that for some of our working groups, they wanted to really have mailed brochures and mailed posters rather than just social media. So making sure that you have the budget to be able to print, and then the ability to also mail out these packages with all the information that you need. So making sure that you have someone, money and time and personnel to do this part, I think is really important. And then using every opportunity. So whether that is connecting with people who host cultural classes and presenting at those cultural classes, or tapping into healthcare fairs that are happening around the country. And even if you can't attend, sending them brochures to disseminate. So really just thinking of all the ways that you can disseminate and using every opportunity that comes your way. Next slide. So in the dissemination, in terms of the details, it's really important to outline a multi-phase dissemination plan. So not just having one email that you send out, but thinking of maybe a 3-part or 4-part email campaign where you're constantly in waves giving people the information. And then also thinking about social media ads and social media postings. So I think it's important to have your first drop of information, and then maybe a few weeks later to have a second reminder or a second email when you do a social media ads, maybe every few weeks, having something that's new and bringing people to talk with their information again and reminding them of this information that you created, and doing that maybe throughout a 2-month or a 3-month or a 4-month period depending on what you have, but having consistent display of your dissemination I think is great. And then organizing dissemination by community. We have we created, as you can see below, a red cap and Excel document that had organization, contact person, email, phone number, and location. And we did this for every community specifically because there were places, for example, like mosques that some communities wanted to target, and some communities really did not want to target places of worship, and that was important to note. And some communities wanted to target specific community groups. So having an Afghan, a Congolese, and a Ukrainian spreadsheet that was very community specific, and then having one at-large spreadsheet that could be used to disseminate to these national and local organizations that kind of work with all community groups. And then having a way to systematically track and disseminate their targets and engagement. So I think having something that's standard red cap is really helpful. So you can have a list of everywhere you want to disseminate, and then also having a list of tracked how many people have responded to your emails, how well are your ads doing, how many people are viewing your ads, thinking through all the ways to, look at engagement is really important. Next slide. The final part for dissemination is social media expertise. I think it's really important to ensure that your team includes someone who is an expert in dissemination or a social media person. Not everyone has the social media talent or can really work on Instagram or Facebook and really understand how to disseminate. So if you don't have someone like that on your team, I think it's worth creating a budget early on to hire a consultant. Because if you do all the work to create this beautiful material, but you're not really putting in the equal amount of effort to disseminate, it kind of becomes a lost cause. So I think it's really important to make sure that that is also being equally funded. Identifying each community group's unique social media habits is also really important, and there's a few ways to do that. One, I think creating a multi-generational working group from the start is really important. That helps you identify what every age range is using. And as we know, social media is used very differently depending on your age range, depending on like your interests, what community you come from. Keeping in mind that some people might be using social media in their home language and not just in English. And so keeping in mind the ads and the pages they might be following. Also identifying what we had called lookalike groups. So identifying certain pages or community Facebook groups or social media pages that people were following or that people were really engaged in, so that when we're targeting ads, we can make sure that we're targeting, whatever the specific community was really invested in or involved in on social media to make sure that everyone is seeing it. And then just understanding all the different ways that people prefer to get their information. There's like obviously the standard of like Facebook, Twitter, Instagram, but there's also in especially like refugee newcomer groups, WhatsApp and Telegram are really important platforms and a really important way of how they get their information. And if you have working group members who feel comfortable posting in those platforms, that's a really great way to disseminate information and being aware of all the different ways and the different age ranges. And then I think lastly, it's considering your institution policies on posting and buying ads on social media. We, for example, realized that some institutions won't allow you to buy YouTube ads. And one of our things is the video. So figuring out ways to work around that or figuring out other ways to post on social media, just being really aware of what your abilities are and the institution that you work at. Next slide. Thank you all so much for having us today and presenting. We have some time to do questions. I think about 10, 15 minutes to do some questions. I think the chat's open for people, correct? Yeah, let us know if you have any questions.
And there's a Q&A function, so feel free to use that, attendees. Thank you all so much. That was such an interesting and presentation. You're doing such important work and I learned a lot. So thank you. I'll kind of kick things off. I think one of you mentioned in the slide, you advised us to kind of be prepared to be surprised, which I think is great advice. And I was wondering if one or more of you could share any other surprises that you had as you were doing this work or challenges you encountered that you were not expecting. Because those are the kinds of lessons learned, I think, sometimes we don't read about in our published academic journal articles. And so some of us make the same mistakes others have made, not knowing others have already made them, and we can't learn from each other. So I wonder if there are any things that jump to mind for any of you.
Yeah, I think we'll all have something to share on that point. I think what's interesting for us in this project, we are working with these incredibly informed, insightful, and experienced working group members. It's really a privilege to learn with them. And I think they were surprised that we really wanted their in-depth guidance for every stage of this work. And so it was really important to be, to like keep going back to that idea that this was going to be in phases and each phase would benefit from their guidance. And so I think that power, the sort of the importance of orienting a group to your goals and the expectations and the fact that they have this deep expertise to offer in many different ways is really important. And from a pragmatic standpoint, that means you have to budget time for that. So it means that first orientation meeting has to have time for that. And then it means that at subsequent working groups, you kind of have to reground yourself in that and both at the beginning and the end, I think. So that might be one really pragmatic point.
Yeah, that's a great insight. And, I have a similar experience with kind of thinking about qualitative work, like these community engaged activities, just like qualitative methods and analysis always take way more time than you expect, and that many people assume who haven't done that work or haven't had experience doing it. You're absolutely right. You really have to build in a lot more time if you want to do it well. Yeah. No, thanks, Kate. Others on the team, any surprises or challenges?
I don't know if this was a surprise, but it was one of those welcome reminders, which is, for example, with that vaccine schedule that we showed you, like as a pediatrician and someone working in public health, I spend like every day looking at that schedule. Like that is very familiar to me. And so I really valued the opportunity for the working group members to bring up, like, this is not clear. Like, why would you think it was clear? Or like the language around a catch-up schedule, like we're going to do a catch-up schedule. And it's like, what are we catching up to? What does catch-up mean? How does catch-up how is that interpreted, or how is that translated? And so I really appreciated the opportunity to zoom out from something I'm thinking about all the time and then like learn hand in hand with the group. And I think I imagine everyone on this call does the work that they do because they appreciate those insights, but that's like a very specific one I had on this project.
Yeah, I mean, that's such a good point, Beth. Can be so myopic in our perspective because we're just in it every day, and things like that become kind of second nature to us. So it's important to remember that it's not that to most other people. Yeah.
And I think I can add up to what Dr. Kate and Dr. Bev just said about time and also stepping back. In regarding of like creating materials, I really, I think that's something I'm still learning. Like when you're creating materials, although we insist on like use the plain language, make sure things sounds like everyday language that you can use. But when you're translating to another language, sometimes you'll be taken by surprise, although you understand what is being said. Yeah. But when you try to capture the meaning into another language, it can really change the entire context of the message that you are trying to communicate. Really stepping back and be open and flexible to revise the material that you have created to make sure that when it's translated, it's actually captured the same accuracy that it had in English. I think that's something that we are continuing to learn and we have been observing throughout the process.
And just to add to that, we know the GSU PRC folks, you have a lot of multilingual experience, but we really hope for a public health audience who aren't as experienced. What Nadej shared will be one of their takeaways, because one of the things in the very first working groups they told us is if the translation doesn't make sense, people aren't going to trust the information. And so the time and the attention to the thoughtfulness like that Nadej brings, for example, to communication is actually part of making your message credible.
Oh, that's so important. And really underscores why just sending an English version of something to a translator and having the person just translate it into the other language is not sufficient, and can actually do harm, right? It's not just that it's not going to be effective, but it could actually take you backwards.
And that it'll be different for different communities, which is, something they shared with us as well. So for some communities, there might be translators where there's a more standardized language use. Maybe there is national media that people were using prior to migration to the US. And so it becomes less complex. But even then, the community review step, I think, makes a big difference.
Yeah, the slide that you all had on, I think it was the Kiswahili example where you had it translated, and it was so, it brought up so many issues, right? That translation was not only can it not be effective, but it could actually really alienate people, right? That there were maybe some words being used that were not the right words at all. That was really a profound example. Let's see if there are any questions. It looks like, Michael Erickson was asking about, did you have the CDC funding through like COVID vaccine dollars? Is that the source?
Yeah, this was initially a project exactly funded through some of those public health funds. Yeah, thank you for that question.
So what are next steps for this project at this point?
Yes, I can kind of answer that. So we are working on like the final draft, making sure that everything is culturally correct and is like perfectly translated. And then our next step is disseminating. So again, like I mentioned, connecting with different organizations, doing presentations, printouts, just kind of getting the information out there. And we hope to do that in the coming month. So yeah, that's kind of our next step.
And then one of the working group requests from the Afghan group was to have similar information available for pregnant individuals, to have more information about which vaccines were recommended and safe during pregnancy. And so one of our colleagues who couldn't join us today, Dr. Mohammed Iqbal, is going to be working on that with us as well.
And we'll also be following the analytics on the information we share. So trying to learn what's working well, what's not working well, and then having the opportunity to share that as part of a process with colleagues so that we can all continue to learn about what's the most effective approach.
And are the tools that you all developed, are they on the NRC RIM website, or how can other communities across the country access what you've developed and share them in our communities?
Yeah, thank you so much for that question. That's exactly right. As these are launched, and the translations will be available on the NRC RIM website, along with an English language version. So individuals who are not multilingual will be able to have some grounding in what they might be sharing and be able to decide if there are other audiences who might find it helpful. Okay, great.
We have you on our list for dissemination on our spreadsheet. So we'll look forward to sharing with you an email.
Okay, great. Well, I look forward to receiving those and sharing them in our communities more widely. And I'm so eager to be able to further the dissemination, because it's clear that you all put so much time and energy into developing these materials. And to your point, to all the points that all of you made, it matters kind of how, the quality, the community input. And so I think I have trust in the quality of these materials, and I think our community members will as well. So thank you so much for this important work and for your time today. We really appreciate it. And just wanted to share with other attendees as a heads up that we have one more Brownbag webinar for the year. Manka Nimkenberg, and she's going to be talking about culturally immersive psychoeducation intervention for Black immigrant older adults with dementia and their caregivers. It's the Black Immigrant Project that she is leading, and she's from the University of Minnesota. That's going to be December 7th at 11 Eastern time. So be on the lookout for information about that. And for anyone who also is interested in looking at what we're up to at GSU PRC, we'll post the video of today so you can share it with colleagues. Feel free to email me with any follow-up questions, or if you'd like to be connected directly with our panelists today. And you can also email us if you want to be added to our ongoing listserv. And again, just want to thank Dr. Yun and everyone who presented today. We appreciate your time. Thank you so much for your important work. And we look forward to getting updates and receiving those fantastic materials. So thank you. Goodbye, everybody.